Hello, my name is Jenna Richardson, and I am currently in my last 7 months of the BSN program at West Coast University in Dallas. I am originally from California and came out here just to finish my BSN. I've been an LVN for the last 6 years. In California, I worked in skilled nursing and rehab, and now that I'm out here, I actually work at an urgent care, and I also do in-home case management. This last term, I took research in nursing, and one of our major assignments was a research proposal. The purpose of my research proposal was to see if there has been a significant decrease in medication errors since electronic medication administration has been implemented. In the healthcare field, there are a number of things that can take place that will have an adverse effect on a patient, and medication errors is actually one of the big things. Medication errors account for at least 1 death per day and 1.3 million injuries per year in the United States alone. Looking at that number, it's absolutely staggering considering medication errors should be or are 100% preventable. Karen Hunter, one of the authors of an article that I read, states that medication errors can be described best as an unintended act or as an act that does not achieve its intended outcome. The delivery of a single dose of a medication is the end result of a complicated process involving 10 to 15 steps, each of which offers an opportunity for error. According to another research study, 39% of medication errors happen while prescribing the medication, so either from a doctor, a PA, or from a nurse practitioner. 12% of the errors happen during the transcription process, which could either just be someone that does transcriptions or a front desk person that does them, or even a nurse transcribing what the doctor wrote. 11% of errors happen during the actual dispensing of the medication, and 38% of errors happen during the administration of the medication, which normally falls on the nurse. At times there can be, if an anesthesiologist is administering it, there can be errors there too. Electronic medication administration is relatively new to the healthcare industry. In February of 2000, the first electronic medication administration system was utilized at a VA hospital. Like I said, this was the first one of its kind, and it was kind of the trial and error of it. And they revamped the system quite a bit just from this one ICU that was utilizing it in the VA hospital. Barcode medication administration is what we would mainly be looking at here, and it's what most acute care hospitals have come to use because it's thought to have the best outcome for the patient overall. It has been shown that barcode medication administration has decreased errors by 60 to 97%, but only 10 to 12% of hospitals are utilizing the system. One of the reasons for that is because it could be the cost and just implementing it in general. Most nurses do have a hard time switching over from paper medication administration to an electronic form like barcode medication administration. Barcode medication administration is when a patient has a band with a scanner that you first scan their armband, and then the nurse would scan their badge, and then they would scan the medication, and everything would kind of align. It's almost like a checks and balance system. Some systems you scan in different orders, but for the most case you scan the nurse's badge, the patient armband, and the medication. Medication errors are still taking place in hospitals all over the world. The original thought was that electronic medication administration would decrease the amount of medication errors. For that purpose, the theoretical framework for this research proposal in particular is strictly based on the fact of human errors. Dr. Raymond Penko states that human error is inevitable due to the way human cognition operates. That means no matter who we are or where we are, there's always a great chance for human error. The thing is with medication administration is there are not any gray areas when we're talking about if an error took place or not. Within the error itself, there could be a number of contributing factors, but overall, the purpose of my research proposal was to see if the numbers have improved and if patients are technically safer with the use of the electronic medication administration system, specifically the barcode medication administration. The author will need to utilize quality assurance terms to find out about medication errors. The nurse themselves play a factor in this, but not in regards to the statistics overall. They'll have to utilize the quality assurance team to see what the numbers were prior to implementing a barcode medication administration. The first article I chose to review for this research proposal was titled "The Impact of Electronic Medication Administration Records in a Residential Aged Care Home." This was actually a study done in Australia, and it focused in residential aged care homes. It looked at 2 different units in the same facility. One was using electronic medication administration records, and one was using paper. They observed a morning shift for 12 days in a row. The study focused on the time that it took versus the errors that were made, so it would not be useful for this author's study. Overall, it showed that there was no significance in the amount of time it took, but it showed that nurses using the paper administration forms actually documented their medication administration prior to physically giving the medication, and that was not the case for the electronic medication administration record. The next article I chose to review was called "The Nurse's Perception of a Bar-Coded Medication Administration System." This, once again, wasn't necessarily the most useful in this research proposal, but it kind of gave an idea of what nurses' thoughts were. They used a questionnaire that was given 1 month prior to implementing the barcode medication administration and 5 months following the implementation of the barcode medication administration. It showed that the implementation had a negative impact on nurses' attitudes overall towards the system, and they felt it was more difficult. I believe this is probably because it's hard to accept change as a nurse, especially when you've been working in the field for a long time and you're used to doing things a certain way. Of course, anything new is going to take a little bit of time until you get used to it. The third article I reviewed was actually a synopsis of a research study published in the New England Journal of Medicine. This one was called "Barcode Tech and EMR Significantly Reduce Medication Errors." It was about how barcode technology and EMRs significantly reduce medication errors. It showed that a 41% reduction in non-timing administration errors and a 51% reduction in potential drug-related adverse effects from the errors. This study would be useful due to the overall purpose of the study that this researcher is wanting to carry out for the proposal. It also showed a link between computerized physician order entry and a decrease in errors. And if you think about it, that makes absolute sense. So many times as a nurse, you're trying to decipher a doctor's handwriting, and there's just so much room for error with that it can put the patient in danger. And that's where your critical thinking needs to come in. And if you feel one of those orders is not right, you always have to call the doctor to make sure it is what he actually wanted it to be. But with the use of computers, doctors can actually just put their own orders in, and it's going to come up the way it is that they typed it in. Obviously, you'll still have to use your critical thinking to make sure that it's an appropriate dose that he prescribed, but you won't have that risk of transcription error itself. The last article that I reviewed was the most beneficial to the study to the research proposal that I would want to carry out. It was written by Karen Hunter. It was titled "Implementation of Electronic Medication Administration Record and Bedside Verification System." It states that barcoding systems have been shown to decrease errors by 60 to 97%. One of the hospitals in this research showed that 26 to 35% of the errors occur at the administration part of the medication administration process. The study also went on to discuss how a large portion of Americans have a great fear of being administered the wrong medication, and how the barcode medication administration kind of helps them regain their trust in the healthcare field overall. This research proposal would be a quantitative study because the data would be measurable by numbers. The study of the design is considered a descriptive design because it would be able to provide a picture of a situation that is naturally occurring without manipulation of any of the variables. A set of questions or a questionnaire had been created or was created that will be given to every participating hospital. For this research proposal alone, I believe that 10 hospitals would be a sufficient amount of data for the research proposal. It would give an overall account of recent medication errors and gives an area for them to compare to see if there has been a decrease in the overall number of errors since implementing electronic medication administration. The sample population for this data collection tool would be the quality assurance department within the hospital. It would be specifically directed at acute care hospitals since that's where most electronic medication administration is prevalent, including the barcoded medication administration system. For the questionnaire, an interviewer would give it to the quality assurance team department. It will be the same interviewer at each hospital, so questions can be answered in the same way each time if any arise. This questionnaire may take a little bit longer since the quality assurance team will actually need to go back through their old records to look at the rates of medication errors pre-electronic medication administration. It should not take more than 3 days to complete. For this research proposal, I did not feel that there needed to be an informed consent because the hospital names would not be listed in the research. It would just be a city where the hospital was located. Therefore, future patients couldn't use this study against them. It's just to gather data to see overall how the barcoded medication administration system is working out for acute care hospitals. Since a questionnaire was used for this research proposal to collect data, it would be relatively simple to analyze, and it's a good way to obtain data in a quantitative study. Descriptive statistics will be used when analyzing the data at hand. This is the most reasonable method to use because it deals with the collection and presentation of data used to explain characteristics of variables found in the sample. To put it a little bit more simple, Schmidt and Brown states that it describes, summarizes, and synthesizes the collected data. The findings would be able to be displayed in a bar graph for easy interpretation, and mainly for the bar graph, you would be looking at what the decrease was or increase in medication errors according to the questionnaire that they filled out. With a bar graph, it's easy for viewers to see the difference, and it's something that you could even display on a unit for nurses that they could easily look at. Like, even if they don't like it, it shows that overall it's safer for the patient, and sometimes a visual like this showing the numbers, the decrease in numbers, especially if they're high, will kind of give them an incentive to be more positive about the change that was implemented. The bar graph shown here is just a sample with numbers. There was actually no data collected. This research proposal is very significant to nursing because, as we discussed before, medication errors are still a huge problem and are putting patients at risk every day. Even though there's been a relative decrease in the overall number of medication errors since implementing barcode medication administration, not all hospitals are utilizing the system. If we could show with more research studies like this proposed one that it actually does benefit patients, I think it could be either mandated for hospitals to use it across the nation, or many more hospitals would be prone to using this to save themselves in lawsuits due to medication administration errors. This research proposal also contributes to nursing because I feel that when people utilize the barcode medication administration system, they feel that it's almost error-proof, which is not the case. A medication can be mislabeled, a nurse can still send an IV pump wrong, or fail to check patient's medication allergies. Even though the computer system is supposed to help with the 6 rights of medication administration, overall it's still the nurse's responsibility to perform these checks as well. Computers cannot take the precedence of our common sense and our critical thinking as nurses. The number one purpose behind this study is obviously patient safety, and that as nurses, that should always be our main concern every day when we step onto that floor. In conclusion, since this was my first research proposal, I think that there's definitely plenty of room for improvement. After completing the research proposal, I realized that a bigger sample size would definitely be more beneficial for this to prove that barcoded medication administration could have a benefit. And I feel that this could be the start to have more studies spin off of this, and maybe they could go more in depth with certain information. And I also realized after completing it that different questions on the survey would actually be more useful than the ones I have listed. Overall, I hope you learned something new and enjoyed my research proposal. Next is just a list of the references that I utilized in my paper and this PowerPoint presentation. Thank you so much. Bye.